It's a great pleasure to come. Ross Feldman asked me to do this a few years in a row, and it's always fun to talk about lots of different things. I wanted to say it's really interesting to see two new pharmacologic agents, the PCSK9 inhibitors and this new diabetic agents, altering cardiovascular mortality. I'm not a cardiologist, but I'm an electrical guy. I'm an electrician. But I'm happy that the plumbing is going well, okay? So I wanted to first thing ask the people in the room to identify themselves. So it's a bit late and you've been sitting a long time. So who are nurse practitioners in the room? Do you guys want to just stand up and just stretch a bit? I mean, I'm serious. I've been sitting for a bit. My posture is a bit numb. Family physicians? Most people? Okay. Other people? Cardiologists, internists? A couple? Great. Okay. Let me give you a little bit of disclosures. I've done a lot of guideline atrial fibrillation work, and I've done a lot of knowledge translation work, and so I've done it sponsored by all of the companies that make the novel anticoagulants, as you can see. And I have done some research work with them. I spent a lot of time doing catheter ablation for atrial fibrillation, which we're not really going to talk about today. So this is a hypertension talk or session, and it would be remiss not to mention that hypertension is by far an important cause and probably one of the leading causes of atrial fibrillation. So almost all of my patients have hypertension. The other half have diabetes. Some have nothing. But as you can read here, these are the risk factors for developing atrial fibrillation, and hypertension is a major risk factor. And this is the enemy for us mostly. Atrium not contracting well, blood pooling, clots forming, and if you're unlucky, flipping off and causing major stroke. 20% of the time fatal, 60% of the time disabling, institutionalized, not going home. Bad, bad news. I want to give you a couple of motivations as to why this is important to you, and you probably already know this. First, across all healthcare systems, if you look in your right column, this is the percent of patients treated with warfarin. So even the Scandinavians don't do this well. So if you take all patients with atrial fibrillation who should be on something, there's a huge gap. Now, I'm hoping that the novel agents are going to fill that gap. We haven't remeasured, but there's a huge gap in terms of getting patients on anticoagulants. So that's mission one for all of us, get more people on great therapy to prevent stroke. Mission two is something I'm going to try to suggest this is something that you can do in your own practice. This is to highlight for me a study that was done. It was nurse-led, physician-supervised, guideline-driven management of patients in an AFib clinic. But as you see here, they also looked after smoking, lipids, all the other things, risk factor modification. And in fact, when they followed these patients, the nurse-led clinic patients did much better. Much less hospitalization, and in fact, a mortality reduction. So if you sort of think, yeah, we say AFib patients and, they're sick and we can really make an impact on these people. In fact, when I say we, I mean all of us, because I can only see a few patients. Collectively, you're going to see the vast majority of the patients. So this is sort of an overview of management for atrial fibrillation. And from a primary care perspective, when we sat down to the guidelines and asked, what do we think primary care could or should be doing, these are the things we sort of thought might be important. Detection and treating precipitating causes, and I'll tell you a little bit about what those are. So identifying sleep apnea, thyroid, alcohol, we'll talk about those in a moment. Assessing the thromboembolic risk, and you've heard about CHADS and CHADS-VASc. I'm sure you've heard many talks about these things, so I'm not going to go through all the elements. But that's something that should be able to be done. And then try to evaluate who should be on an anticoagulant and fill that gap. And the last is maybe a crack at trying to slow the atrial fibrillation down and see how it goes. Meaning if you do that and a patient feels really great, then maybe they don't necessarily need to see a specialist. Or if they do, it's certainly not urgent. And if you try that and they feel miserable, then we would be happy to see those patients.